Hi, this is April Morris. I am a nurse practitioner, family nurse practitioner with several years of hepatology and also endocrinology experience. And make sure to use the QR code to record your attendance. Today, we're going to talk about MASLD pharmacotherapy. And so there are three different, you know, when we manage dysmetabolic conditions and diseases, there are three sort of pieces of the puzzle that we definitely want to target. And so the current available treatments for dysmetabolic management is, of course, obesity control with weight loss. Looking at lifestyle modifications, always the first go-to that we have when we talk about, your diet, exercise, physical activity, making sure that people do change their lifestyle. And then weight loss medications, which we'll talk about GLP-1 receptor agonists, as well as GLP-1 and GIP receptor agonists, and also bariatric surgery. In patients with advanced liver disease, you want to choose and dose drugs appropriately. The next thing or piece of the puzzle that we look at is reducing the cardiovascular risk. And so treating type 2 diabetes and cardiovascular risk factors are going to be key to making sure this is well controlled. So treating hyperglycemia, hypertension, dyslipidemia are very important to make sure that we keep those under well controlled. And then looking at targeting NASH, liver-directed treatment. There's been some previous treatments that we've had available, like vitamin E and pioglitazone. And then the new kid on the block is Resmetirom, which we'll talk a little bit more later on in this presentation. And so the first, sort of class or medications that we'll talk about that can be helpful in those three parts or pieces of the puzzle are the GLP-1 receptor agonist. And how these work is that after food ingestion, it is an endogenous GLP-1. It stimulates glucose-dependent insulin secretion, suppresses glucagon, delays gastric emptying, and it also directly acts on the hypothalamus to promote satiety and reduce energy intake. So GLP-1 receptor agonists are analogs of the gut-derived incretin hormone glucagon-like peptide, one, and also it lowers blood glucose and causes weight loss. And so the role of GLP-1s in a hepatology practice. And so there has been studies looking at semaglutide at the 2.4 milligram once weekly dose. It successfully met primary histological endpoints at 72 weeks, showing significant MASH resolution without worsening fibrosis and also significant improvement in liver fibrosis without worsening MASH. So consider administering GLP-1s for overweight MASLD patients with a high priority given to those with MASH or fibrosis. It is really not meant for lean MASH. And so how do GLP-1s affect GI providers? So that is a very important thing to note, that it does delay gastric emptying, which increases the risk of aspiration with anesthesia. And so when patients are going in for their endoscopies or colonoscopies, it is important that they hold their GLP-1 at least 7 days. And if they haven't, then you want to consider, and you should cancel that procedure because of the delayed gastric emptying and the anesthesia risk. And so vitamin E. Vitamin E, the dosing is high dose, 800 IUs per day. It is meant for those non-diabetic MASH patients without cirrhosis. The PIVENS trial was a landmark study that showed vitamin E improved liver histology in non-diabetic adults with NAFLD. It was effective in about 43% of patients, and it showed histological improvements. The limitations is that not all patients respond, and you can't use in the hypertensive patient or the patients with diabetes. So if you look at MASH and the risk factors for MASH, hypertension and diabetes usually is on that list. And so guidelines. In the 2023 ASLD guideline, vitamin E can be considered in selected individuals as it improves NASH in some patients without diabetes. In the 2024 EASL guidelines, it actually states that given the lack of robust demonstration of histological efficacy on steatohepatitis and liver fibrosis derived from large phase 3 trials and potential long-term risk, vitamin E cannot be recommended as a MASH targeted therapy. And so the next, sorry, I skipped through there. The next option is pioglitazone. I'm sorry, it's still going forward when I'm trying to go back. Okay. Pioglitazone. Sorry, pioglitazone, the dosing for that is 30 to 45 milligrams daily. It is an indication for MASH patients with or without type 2 diabetes. The PIVENS trial showed that there was no benefit of pioglitazone over placebo for the primary outcome improvement in histologic features of MASH. However, significant benefits of pioglitazone was observed for some of the secondary outcomes of improvement, which is the cardiovascular risks. The safety considerations, you want to consider that this actually has the potential risk of weight gain. And these patients, the most MASH patients, need weight loss. And so you want to be basically cognizant of that when you want to prescribe this particular medication in those patients with MASH. You want to consider edema, bone fractures, especially in women, and a possible association with an increased risk of bladder cancer, necessitating careful selection and monitoring when it comes to this particular drug class. And so Resmetirom. Resmetirom received FDA approval in conjunction with diet and exercise on March 14th, 2024. It is important to make sure the lifestyle modifications are in play in one of the pieces of the puzzle to use Resmetirom. But it did get approved for non-cirrhotic, non-alcoholic steatohepatitis or NASH with moderate to advanced liver fibrosis, which is consistent in stages F2 to F3 fibrosis. Thyroid hormone receptor beta, it's a thyroid hormone receptor beta agonist. It selectively binds to and activates the thyroid hormone receptor beta receptor in the liver. So looking at the pathophysiology relationship between the thyroid and the liver, the production of thyroid hormones is regulated by hypothalamic and pituitary activity, TSH, thyroid stimulating hormone. Thyroid hormones regulate many metabolic activities, several systems in the body. Thyroid hormone receptor has two major isoforms, and the thyroid hormone receptor, THR beta, is a predominant isoform in the liver. Resmetirom is a thyroid hormone beta receptor agonist that selectively targets the liver. Key mechanism in treating lipid metabolism, THR beta, and hepatocytes upregulating genes involved in fatty acid oxidation and lipid metabolism. This helps break down excess fat in the liver. It increases the expression of bile acid synthesis enzymes, promoting cholesterol conversion to bile acids and enhancing cholesterol efflux from the liver. And by reducing liver fat, it indirectly reduces inflammation associated with fat. And so it also has an anti-fibrotic action. It may help reduce liver fibrosis by decreasing activation of cells, which are responsible for collagen deposition. So that's probably the heaviest slide you'll see in this slide deck. Just understanding how the resmetirom works, how it reduces inflammation, reduces, fat in the liver, and also reduces fibrosis. So the MAESTRO-NASH trial, it's an ongoing phase 3 randomized controlled trial of resmetirom in NASH with liver fibrosis. This trial studied adults with biopsy-confirmed NASH with a fibrosis stage of 1B, F2, fibrosis score of 1B, F2. So a little under 1,000 patients were randomized and equally a 1-to-1-to-1 ratio, using once daily resmetirom milligrams, 100 milligrams of placebo. The two primary endpoints at week 52 were NASH resolution, making sure that it was a reduction or mass by greater than 2 points with no worsening of fibrosis, an improvement or reduction in fibrosis by at least one stage with no worsening of the NAS. Sorry, for some reason it's not advancing. Okay, I apologize. We just went through that slide. Okay, so in the um, in the MAESTRO-NASH phase 3 study, um, the safety profile, it basically saw that diarrhea and nausea were more frequent in resmetirom than with placebo. The incidence of serious adverse events were similar to trial groups. So you see the graph here. You see that diarrhea and nausea definitely, you saw a little bit higher in those resmetirom groups here. And then the primary endpoints. So resmetirom, 80 milligrams and 100 milligrams were superior to placebo with respect to NASH resolution and improvement in liver fibrosis by at least one stage. And so when you consider, so who do we use this new great medication, resmetirom? What's the ideal patient? And so you want to look at those adults with non-cirrhotic MASH they have at least moderate to advanced fibrosis, F2 to F3. F4 is contraindicated, that's cirrhosis, but F2, F3, you want to see that those patients are progressing in their liver disease, and that's who you should consider for. And it's only approved in conjunction with diet and exercise, making sure lifestyle modifications are discussed, or education is there, and making sure patients are changing, improving their lifestyle. And so you want to also consider drug-drug interactions. You see here on the left, antivirals, and a good list of medications that you want to avoid. You would have to reduce the middle column. There's 3 medications there. You want to reduce the resmetirom dose. Then on the right, you see that resmetirom can actually increase the exposure of these particular drugs. And it's good to highlight statins. A lot of our patients are on statins. And so these are the max doses that are allowed when you add in resmetirom to these patients. And so practical considerations for managing MASH with resmetirom, duration of treatment and monitoring. Ongoing evaluation of this continues with the MAESTRO-NASH trial. You will likely need to restage fibrosis with non-invasive tests such as the vibration control transient elastography, or VCTE, PDFF, the CAP score, which is with the VCTE, or the ELF score. So you do want to check those and kind of consider kind of monitoring those patients to see the response. Expert panels are currently working on points and the frequency of testing. And so questions do still remain. Widespread resmetirom use will depend on insurance coverage. Unfortunately, insurance carriers still dictate who we can prescribe this for and who we can get it for. We can prescribe it for everyone, but who can we really get this approved for? It's the insurance companies. And that's just a lot of work, a lot of education, on that, sort of level of making sure they understand how great this medication is and how it can actually improve MASH in those patients who are progressing to advanced liver disease. The frequency of staging and lab testing for monitoring. I think as practitioners, we have our own sort of schedule. When you start a new medication, you see them a month after, and then monitor them every 3 months or so. But we don't really have any clear-cut guidance with this, and so recommendations would be great to have for that, as well as the duration of treatment. How long should we keep patients on this, and when to discontinue? Of course, intolerance, if they have terrible diarrhea or nausea, or people, just can't tolerate it. But if they're tolerating it great, do we just continue, indefinitely? There's definitely some conversations and some considerations of or questions that we still have that are unanswered. And then multiple agents currently in clinical trials. So likely we will have more options in the future. And so visit the GAPP MASLD MASH Community Network to view MASH disease state education and Rezdiffra, which is Resmetirom promotional. Thank you so much. I hope y'all have a great day.